All right. As folks are rolling in, I just want to briefly introduce our presenter today. And I'll actually let him introduce himself more because he's got more background on himself than I do. But we're really excited about today's presentation. We've got Daniel Chipping here from the Institute for Advancing Health Value at Western Governors University. He's going to talk a little bit about some of the research and opportunities that he's had through the Institute to work on health equity and to advance some of the practices that we have happening here in the state of Utah, as well as across the board. So I'll let it go from here, Dan. I think you're good to go.
Awesome. Thank you, Austin. Appreciate you having me today. And thank you, everybody, for letting me join. I think I would venture to guess that I've worked with some of you in the past, and it's probably been a few years since I've seen you when we were back in the days talking about physician quality reporting systems and meaningful use and the like, and quality improvement there with Casey. And just grateful to be back in front of a Utah audience. I'm from Utah, born and bred here, and I've spent the last 7 years now working for an organization that is now called or known as the Institute for Advancing Health Value. I started when I left Health Insight and transitioned from doing quality improvement work in Utah. I took on this project with the Institute. It was called the Accountable Care Learning Collaborative at the time. It was a newly formed entity formed by former Secretary of HHS, who we know as Governor Mike Leavitt, as well as his CMS Administrator, Dr. Mark McClellan. And they built the Institute or the Accountable Care Learning Collaborative at that time to understand the new trend in healthcare nationally that was this term of value and understanding accountable care and what that meant. And so they wanted to convene the industry and say, look, we know things are changing and we want the industry to work together to break down silos, to learn together and to understand these new models that are coming out and understand how care delivery really needs to change in response to these things and the goals that we have. And so today we're going to talk about value-based care or accountable care or health value. You know, there's a lot of different terms for it. Population health is another term that's frequently used. We're going to talk about those things and the connection between those and health equity. So today I'd like to just propose, I'm going to wax philosophical at the start and the end and a little bit intermittently throughout the presentation and let you guys think a little bit about some of the direction that we're heading. But we're going to talk a little bit about the history of value-based care, you know, the importance, why this is a term and a focus for our nation. And then we're going to talk about the progress that we've made in value-based care. And then we'll finish about talking through how that's applicable to health equity and what that really means. And then because I have a national perspective, I'm going to talk about a lot of, you know, high level national numbers. And so it's going to be less focused on Utah. Forgive me. I apologize. I'd love to do a Utah value-based care presentation one of these days, but I wanted to give you a national high level perspective to start with. So with that, let's dive in and be philosophical together and consider how do you know when you're lost? And, you know, I thought about this question and I came up with three telling features to know when you're lost. You're not where you want to be. You're not sure how to get where you want to be. And if you can't answer those two conclusively, you might say, well, am I surviving? Am I kind of coping in this situation that I'm in? Or am I really thriving? Is this really where I want to be? And am I excited to be here? And so if you want to discover if you're lost, you've got to ask yourself those questions. Where am I? Is this really where I want to be? Am I thriving or surviving? And then obviously there's another question. If you feel like you're lost, do I know how to get to where I really want to be? So having planted that seed about whether we're lost or not, let's dive in and look at where we are in our current status in the healthcare world. So the question is, where are we? And is this where we want to be? Governor Leavitt says that as a nation, we're faced with two very important but competing priorities. And those are, number one, to provide the best care possible and number two, to be competitive in a global landscape. And so, as you can see here, we in the US are spending almost twice as much. These numbers are for 2019, and there's more current numbers that are more like 18. We actually did hit 20% this year, and then backed off of that again a little bit in 22. I mean, when I say this year, but we're spending almost twice as much as the average national economically developed country that's comparable to the US. And so one would think, where's all this money going? This must mean that we're incredible. We're doing amazing things. And you definitely can't argue. Brent James, the statistician who made Intermountain Healthcare famous with his quality improvement initiative, says that we are amazing at rescue care. Rescue care, no question. We do emergency care really, really well. But then you look at where all this money is being spent and the other outcomes that we're achieving, and you start to question. And so you see that in matters of population health, such as life expectancy at birth, the US is doing very poorly compared to those same economically developed countries. And so the money is definitely not improving our outcomes in that regard. And there are many other population health outcomes that you can look up. And this health system tracker that's produced by the Kaiser Family Foundation analyzes many of these population health outcomes that you can look at. I just grabbed the one chart to reflect the poor outcomes that we see. So the additional spending is not helping our health outcomes. Additionally, you see things like, sorry, my clicker isn't working, going through. You see things like how much we spend on primary care compared to the other countries. And so on the left, you'll see that we only spend about 5, 6, maybe 7% of our healthcare dollars in primary care. And you compare the US to these other countries, and you see that we have very much fewer, or far fewer, physicians per 10,000 people, especially general practitioners and primary care physicians. And so we're definitely not investing in prevention. You come to this, what I know you all are feeling is, the physician shortages, the care deserts. When you think about the rural scenario, when we've got 2/3 of hospital closures have been in rural communities, and 135 rural hospitals have closed since 2010, and you've got only 13 physicians per 10,000 people in rural areas compared to 31 in urban areas. And so this is another this is another signpost of where we are. We're short 1 million healthcare workers today, with extreme stress on the system. And we'll talk more about that coming up, which obviously impacts our burnout rates. Our physicians and our clinicians, our care teams, are doing so much work for our patients, trying to help manage all of the needs, and they don't have enough manpower and people to do it. And so we see that the great resignation severely impacted healthcare. 54% rather than just 40% of people nationally who left their jobs because of burnout. And it's been proposed that burnout is not sufficient to describe the pain that physicians and clinicians are feeling related to their work. Moral injury is when you're forced to do something that violates your moral compass or your conscience, and you have to take part in that. And it's against your own moral values and personal principles. And I think that in my conversations with healthcare people throughout the nation, this is a common feeling of a thread that runs through people's minds, is that they're being forced to do things in our current environment that run directly counter to what they intended to be when they signed up to be a caregiver or a clinician. And so, speaking of one of those things, when physicians take the Hippocratic Oath, they promise to do no harm. But then we see that causes of personal bankruptcy, the number one cause in America is medical issues, medical bills. So people can't afford care, and they're being hounded to pay for it. And we see that nonprofit hospitals and many other hospitals are aggressively pursuing unpaid medical bills and pushing people into bankruptcy and causing a very significant financial harm which, as we know, creates additional stress and challenges for the patients that we're trying to serve and create health for them. So how did we get here? That's another question that's kind of important as we think about this journey. We don't want to repeat the same mistakes we made. We don't want to keep following the same path. So healthcare has become a business. It's become, we've applied business principles to healthcare where we've been reimbursing on a piecemeal rate. We don't really understand the costs of healthcare. And so we just say, we think this is a good representation. We reimburse on that. Economically, economics state that a person's willingness to pay determines how much something should cost. Well, for healthcare, we know that people are going to pay almost anything to stay healthy, to have life, to extend life. And so we see that, healthcare is behaving how economics says it will behave. Prices are increasing significantly because of consumers' willingness to pay. So these are just a few of the things that indicate where we are. And so now my question is this really where we want to be? And I think the answer is no. We all understand that we want to be somewhere else. And so we come to the triple aim. And this is a vision that was painted for us by Don Berwick. He wrote about this in a journal article, and I'm not recalling the journal it was in, but it was 2007 where he presented this. And the triple aim was to provide the best care possible, to achieve the best outcomes possible, and to do that at the lowest appropriate cost. And this is obviously a much better vision of where we want to be. And the question is, how do we get there? And so another way to state this is where the industry has gone with this is they've called it accountable care. They say it's care that centers on the patient and aligns to support shared decision-making and realize the best outcomes for all. And I'm going to skip the last part because that's kind of an update, and we'll get to that here. But essentially, accountable care, if you define the three principles of accountable care, it's the best outcomes, the lowest appropriate cost, and it's for a specific population. History, and we'll talk more about that, that last piece. And so when we paint the picture, the vision of where we want to be, we have the IOM Crossing the Quality Chasm report that says we want care to be effective, safe, equitable, accessible, patient-centered, et cetera. We know that we want it to be relationship-based. I think that's, when physicians are learning to be physicians and practicing and building relationships with patients, or even before that time when they're thinking about what they think care delivery looks like and building those relationships. We kind of want to go back to that where the relationship was the most important thing between the physician and the patient. But we also want to recognize that we have data. It can be data informed, and we can use that data at the point of care and have information that we've never had before that'll help us understand where we can care for that patient, what we can do to care for that patient better. We also have data that can help us be proactive, that can help us identify problems that are not necessarily visible in a reactive patient visit when you're just seeing the patient when they come in, but that can be preventive, that can be thoughtful ahead of time and help drive the right type of care and the right type of outcomes. And so these are things that we recognize what we want care to look like. I think Dr. Neil Wagley said it well. This was an interview that I and my executive director did for our podcast, The Race to Value. And he's the CMO at Devoted Health. And he says, the first task is to make sure our patients feel like family. Longevity is not the ultimate goal. It's really understanding if you feel like your patient's like family, what your family members prioritize or what that patient is going to prioritize and value. And then that becomes the ultimate goal and helping them achieve what they really want. So the question is then, how do we get there? And this is where value-based care comes in. Value-based care is about aligning incentives. For too long, we've been in a world that's been fee for service. It's been focused on quantity. It's been focused on procedures. And now the new models are about creating incentives that align with the reasons you went into medicine, allowing you to spend time with your patients and build those relationships and provide care not based on what's reimbursed, but based on what the patient really needs and what you can do for them. And It's about creating a system of support along a full care continuum and being able to coordinate that care and understand each person's role on the care team, and not just the siloed care team in your facility, but across the community. And then being able to really promote quality again instead of quantity. So having said that, we turn to alternative payment models. And this has been the government's, I say the government because CMS is really where the bulk of this national effort has come from, and where they've had the most leverage to influence it nationally. And they say that an alternative payment model gives added incentives to provide high quality and cost efficient care. And so let's dive into that a little bit more and understand what alternative payment models look like. The HCP LAN, or the Healthcare Payment Learning and Action Network, is a public-private partnership that's dedicated to thought leadership and strategic direction and support to accelerate the adoption of accountable care, or the adoption of alternative payment models. And so the LAN was great because they created this categorization of payment models. And you can see that category 1 is fee for service. That's where we've all lived for too long. Category 2 is fee for service plus a bonus. You can think of PQRS, quality reporting measures, and earning a little bonus because of that. You can think of meaningful use because the measures that you met for that. You can think of MIPS. A lot of MIPS is here. Category 3 is when you start to get into shared savings. And part A of category 3 is shared savings with upside only. So you're basically saying we're going to get our toes wet in value-based care. We're going to go try to do shared savings, and shared savings means that if we meet certain benchmarks with Medicare, that we have a certain amount of savings and improve quality a certain amount, then we will qualify to share whatever money we saved the system, with Medicare, with the claims that they would have paid us. We'll split the difference, and there are different levels of how much shared savings you can have. Part B is where risk comes in, where there's downside risk. And again, there's different levels of downside risk, but this is where you'll see programs that really start to move, where people believe that this is where the needle really starts to move, where value-based care really becomes effective, is providers taking and sharing some of that risk and being closer to that risk with the insurance companies. It puts more skin in the game, so to speak. Category 4 is where you get to things like bundled payment and capitation, where you're basically given a global budget, capitated payments, whether upfront or retrospectively, to pay you, and then your losses or savings are based on whether you spend more or less than that capitated amount that you receive. So this framework is really helpful in understanding value-based care models. And we'll talk more about those then also as we go. The LAN will come up again. So, all right. So the question is, has the alternative payment models that have been introduced and have the work that's been done with alternative payment models, are we there yet? Have we reached our journey? I think of the kids in the car when I drive to California. Are we there yet? And so we'll just do a quick overview of where we are on the current state of things. So our progress to date is we've been about 2 decades into this. Governor Levitt says, and I refer to Governor Levitt, if you haven't read his book, Finding Allies and Building Alliances, it's a fantastic read. But he says the way to solve complex problems is through collaboration, which is, again, another reason why they founded the Learning Collaborative, which is now the Institute. And he says that it'll take 25 years into at least a 40-year process for change. And, he talks about a story about, if you guys are as old as I am, maybe some are a little older, you can remember the days of ATMs when every bank had its own ATM, and the collaboration that the financial industry had to go through to create a one ATM, a one kiosk solution for a person to access their bank account or their credit union account anywhere they went. And so when you go to the airport, instead of seeing 20 ATMs lined up all next to each other, you just got one. And it was a Herculean effort, but it took collaboration, and it took organizations who were willing to look past their own profit interests and their risk of sharing private information or IP that they wanted to keep secret. It took sharing some things and being willing to commit to this as an industry for them to solve that problem. That problem is not nearly as big as the problem that we have to solve in healthcare. So here we are 25 years into a transformation that's going to take a significantly long period of time. And we know that there's bipartisan support. 20% of the GDP is not something that anybody wants to see on either side of the aisle. So there's bipartisan support that we have to come up with a solution that really drives the prices down, but does not reduce the care, but actually improves the care that people receive and improves the outcomes. Because frankly, as a nation, we are a caring people. We do not want to see people left behind. We don't want to see people who are suffering and hurting, and especially as healthcare workers. And so having said that, our progress to date, 20 years in, we've had over 50 models that have been introduced. Only 5 have had statistically significant results. We see that there's been some fluctuation, but we're at a point now where over 1,200 organizations have held contracts. 340 of those have dropped out by 2021. But we're also seeing a very small amount of reimbursement to physicians that's actually tied to value-based care. So that's kind of one of the most telling factors is, are the physicians being incentivized based on value-based care principles, or are they still stuck with fee-for-service incentives? So having said that, we'll go back to the HCP LAN. The HCP LAN, or the LAN, they run a survey every year, and they get a great response rate from managed care organizations at the state level, Medicare Advantage plans, commercial plans. They also get feedback from provider organizations. And so they're able to tell about how much of the payments are flowing through these different models. And so if you recall, category 4 and 3B are the ones where you see the most risk involved, where you see people with they basically jumped into the water. They're still straddling 2 canoes, because even as you can see here, even commercial payers, which thankfully are as traditionally they do, are following Medicare's example. But you're seeing that everybody only has a small amount in the green and the dark purple that's actually flowing through real high value-based care types of contracts. And so there's a lot of work to do. There's been some growth in this over the past year. It's actually been a little stagnant for about 3 years. We haven't seen a ton of increase. But we are seeing things grow. And so we're making some progress. I'll go into a little bit more detail from each of the payment stakeholders, each of the payer stakeholders. So Medicare introduced Medicare's first initiatives into value-based care were the hospital readmissions and reduction program and the hospital acquired condition reduction program. These were both disincentive programs. They came with penalties. And because of the penalties, they were significant enough to actually cause some improvement. And so we've definitely seen improvement through these programs. But that was kind of the first foray into Medicare trying to really increase value, reduce the costs. Sometimes, my apologies, sometimes my arrows work and sometimes I have to click with the mouse. And so I'm never sure which one is going to move the slide. Sorry for the delay. Also, Medicare in 2012 launched the Medicare Shared Savings Program, and that's the first ACO program that Medicare launched. Now, ACOs, accountable care organizations, just as a reminder, they're focused on accountability for a population to improve costs and improve outcomes and reduce costs. And so since 2012 through now, we've got about 10.9 million beneficiaries, and that's the number that stayed kind of consistent since 2018. We've actually seen a drop in the number of organizations who are involved in accountable care. And that's partly because Medicare, a couple of years ago, they initiated a Pathways to Success program where they tried to accelerate the adoption of risk. And a lot of provider organizations didn't feel ready for that, and so they dropped out. But we have seen the number of beneficiaries maintain, which is a good sign. They've saved 3.6 billion in 2021. The number's closer to 6 billion when you look at the number of years overall that have where money's been saved. And so a few things we've learned through this process: that ACOs that are in two-sided models save more, and ACOs with more contracts in risk, so they've had greater maturity, they've been in it longer, they also have greater savings. And not surprisingly, physician-led ACOs have the most savings when compared to their hospital ACOs or the hospital/physician group ACOs that are a partnership. And so it should be pretty simple to recognize why, because physician organizations are the most aligned with the incentives that are created, where hospital organizations are definitely faced with some challenges when it comes to reducing revenue. When you're talking about reducing admissions, reducing readmissions, decreasing length of stay in hospital, you're kind of targeting those big ticket, high cost items with value-based care. And then the next group is Medicare's innovation area, which, if you recall, maybe you know this, maybe this is new for some of you, but in the ACA, the Affordable Care Act, when that was being passed, Dr. Fisher from the Dartmouth Institute and others had been, and Dr. McClellan, the CMS administrator under Levitt, they had been talking about accountable care organizations and planting those seeds in Congress. And so when the Affordable Care Act was passed, there was actually a couple of pages out of that 1,000-page document, 2 whole pages that said, we need to test new payment models. We need to try things that are different. We've got to experiment and see how we can create value for the patient. And we can't do that if it's going to require congressional approval every time we want to make a change. And so the reason the MSSP program is under the CMS slide is because that one does require congressional approval. And then those other 50 plus models that I mentioned earlier, those ones fall under CMMI. So CMMI is the Centers for Medicare and Medicaid Innovation, and it was created then through those pages in the Affordable Care Act that allowed for practicing and experimenting to learn what are the levers that we actually have and how can we influence and drive value. So Medicare CMMI created many projects, a few of which I've listed here. CPC Plus, I think we're probably all pretty familiar with, was focused on primary care organizations. And it increased spending, it was found, just a little bit, not necessarily statistically significant. The thing that I want to point out here is that the increased spending for CPC Plus, even though that demonstration project ended, there are many that feel that that increased spending was actually very appropriate and necessary. There's a lot of legwork to get primary care practices, especially for small independent organizations who don't have the infrastructure, the data analyses, the actuaries and the people who can actually do some of the work required for risk. They need additional support. They need additional spending. So when I see that it increased spending, I say, good, we need to do more. Next gen ACOs, that ended in 2020. That was the most risk that a model allowed a provider to take. But they found that that one also had a little bit of increase in spending. They closed that project, but they've tied in lessons learned from that demonstration program into the upcoming models that we'll talk about in a minute. Bundled payment models, these are models that are, instead of being focused on a population, they're focused on a specific condition, like joint replacement or some other episode like a hospitalization. But they found that these are still questionable. There are a lot of people who still believe in bundles, but for the most part, we're seeing that that they save money, but a lot of that time it's dependent on reducing admissions to SNFs and to IRFs. And so again, that's questionable as to whether that's necessarily appropriate, because the right level of care for the patient. We have seen some instances where patients are sent home too soon, and then the readmission occurs because they tried to skip the SNF or they weren't in the SNF long enough. So still up for debate on bundles, but bundles, the BPCI advanced program has been extended for 2 years. One of the things we did see with some bundled programs is that there was a mandatory model for a little while, and once the mandatory portion was removed, a lot of the people who had been in mandatory areas dropped out. And so there's a lot of legwork that goes into redesigning your delivery processes and your infrastructure to support these types of models. And so we've definitely seen people drop out when increased risk pressure is placed on them, or the timelines are accelerated, or if it's not mandatory anymore. And so that gives us an overview of kind of the government's approach. I will say that for commercial, again, we've seen a little bit of a plateau. Commercial's tricky because we don't have visibility into commercial organizations very well. They keep their data pretty close to their chest, and they publish things that say they are improving outcomes and they are reducing costs, but it's not with data that can be verified and validated by independent parties. But we do know that Aetna has more than 2,000 value-based contracts. Anthem Blue Cross is partnering with organizations that we call aggregators or enablers. I think many of you may have heard of Aledade. I know that they've played in the Utah market and have been convening physicians and pulling them into their model. But these are organizations that do upfront investments for provider organizations and help them build the infrastructure and build the teams and build the knowledge and skill sets that they need before starting their value journey. And then they do a split of the shared savings afterward. Humana, also doing a lot of value-based care. They release a report every year that's their value-based care status update. And their previous report, their brand new report just came out, and I have a podcast episode interview with Kate Goodrich, their CMO, that you can hear about that. But this is their previous report that showed 68,000 primary care physicians in value. 67% of their MA beneficiaries are in a value-based payment arrangement. And then Optum Care, they're a little bit more, what's the word that I want? It's not as easy to tell. They're a little bit more secretive, but we know they have 60,000 doctors that where they own the practices or have affiliated partnerships with, and we know that they do place a strong emphasis on value-based care, evidence-based guidelines and things, and they do have reimbursement models that tie to their physicians, practicing or being paid based on providing value. Medicare Advantage is an interesting one. We've seen a ton of growth in Medicare Advantage over the last few years. We've seen that 57% of payments through Medicare Advantage for Medicare Advantage beneficiaries are tied to value. There's currently 48% of Medicare Advantage patients, Medicare patients are in Medicare Advantage, and we definitely see that number increasing quickly over the coming years. There's a challenge with Medicare Advantage and an argument that's happening right now, and that's whether Medicare Advantage is actually increasing costs and increasing quality enough to justify those costs or not. And so there's some great health affairs articles, kind of an argument talking about Medicare Advantage, if you want to dive into that more. As far as Medicaid is concerned, again, this is where I'd love to spend some more time talking about Utah specifically, but we see 41 states contracted with managed care organizations. Payments to Medicaid providers are up. 29 states are now requiring the use of value-based care. But we only see 16% of Medicaid payments that are tied to risk. So it is growing, it's growing slowly. There's some great examples out there. I do want to highlight on this slide that there are actually also non-risk value-based care programs out there. And one of those that's just the kind of the shining example are FQHCs. FQHCs have been providing better care. They have statistically significant better outcomes, better quality than other care providers, and they get paid less to accomplish that. So FQHCs are a great example of value-based care without the risk. There are others. There's the CCNC, which is a Carolinas program that started over 20 years ago. There's Oregon has their CCOs. There's a Vermont Blueprint for Health. There are a few studies, and I'm happy to share some of these links with you all if anybody wants to learn more about those programs that show provider organizations who are not taking risks succeeding in providing value. So the question then becomes, how much farther do we have to go? Are we kind of getting close to where we want to be? And the trick is that value-based care has not been a panacea answer solution. Dr. Sachin Jain wrote a great article that was published in Forbes, where he identified that value-based care also has unintended consequences at times. If we're trying to avoid hospitalizations and the high cost of hospitals, we might sometimes not send somebody to a hospital when they should have. Same goes for a specialist. One of the biggest levers we have to reduce costs is focus on a really high performing network. And so we'll get a very narrow network. And then sometimes those narrow networks exclude providers that patients really want to see, where they have relationships, or where that network is more focused on price instead of quality. And then we can see the pro teamwork. If you're pro teamwork, which is a great principle, that you share the load and you take the burden off of the physician and let the physician practice at the top of their license. There may be times when somebody on the team doesn't recognize that a patient should have been referred to the physician, and that they should have time with a physician. So there are definitely incentives that value-based care still makes a struggle with, but so we're essentially seeing that. I'll just highlight a couple more. MIPS has penalized clinicians who care for poor adults. We've seen that that's actually perpetuated structural racism. We've also, with the Medicare hospital programs, that's actually taken resources away from safety net hospitals and widened those inequities. Sometimes we've seen ACOs drop high-risk beneficiaries because they cost more, and so they want to focus on the patients that are easier. A lot of the value-based care principles drive, addressing modifiable behaviors. And if you have high-cost patients that are high cost and there's nothing you can do about it because it's a cancer and you can't modify a behavior to improve the outcomes, then there are care systems that will cherry pick their patients. Also, value-based care has added, quality measures has always been a challenge. We've always known that we have too many people asking for too many quality measures, and trying to create alignment between those is very difficult. And so getting multi-payer models where you have cohesive agreement on quality measures is still something we're waiting for. Also, we've got the challenge of evaluating models that we want to be in at the same time that we're trying to prove performance in a certain model. And we don't know if we're performing well because the data lag of performance comes 6 years after we finished our performance period. But at the same time, we've had to make a decision if we wanted to go adopt more risk for the next year, or if we need to, pull back or stay in the same program we're in. So these are all kind of some challenges that we're seeing with value-based payment. And so we've recognized that value-based payment is not the end unto itself. And so going back to that analogy with the kids in the car, I've recognized that, Uncle Uncle Bill's house doesn't have enough room, we can go to Aunt Jenny's house. She's got a few more rooms for us. It's going to be a little nicer. We're going to have to travel a little bit farther, but the destination is going to be better. And so having said that, we've recognized that the triple aim doesn't quite achieve where we want to be. We saw the quadruple aim come about in 2014 that addressed clinician well-being. We know that if providers aren't happy, that the patients aren't going to do as well, that they're not going to receive as good of care. And so we've seen that we recognize that clinician well-being is very, very important. And that quintuple aim is very much more recent, where we've added health equity. And so this is where we get to the part where we say, okay, how does value-based care impact health equity? And so I think we've all seen this slide. CDC defines health equity as the state in which everybody has a fair and just opportunity to attain the highest level of health. And you can't just do the same thing for every patient. Obviously, you've got to meet the patient where they're at, understand their needs, and address those needs appropriately and individually. I think you've probably all seen statistics about health equity and how we don't have health equity. We recognize that that's a big gap. And so I'll leave that there. You guys can look at that. I won't talk through each of those. I want to jump to a couple other things, but I'll just call out that access to primary care is a huge barrier to achieving equity. We see that people in underserved populations go to the ED department or the emergency department much more frequently. And we think that's because they don't have the access to the primary care. They're living in areas where primary care shortages exist, or there's not trust with a primary care physician. And especially we see that problem severely in rural America, excuse me. Sorry, one sec. When you talk for this long, you've got to stop for water every now and again. So just a couple more examples. We definitely know that health inequities are more severe among people with lower incomes, among those with poverty. And we even see it with Medicare Advantage, which, a Medicare program should be pretty holistically, available to everybody. But we see that Black and Hispanic beneficiaries tend to choose the programs that are evaluated lower and consider, they're a higher likelihood of the program actually being terminated. So they're definitely not getting the care that's appropriate. One that I want to highlight, we'll be addressing in an event that we're hosting in early April, which will be around maternal health for Black women. It's Black Maternal Health Week I think it's April 7th or April 11th. And we'll be doing a podcast episode and a white paper, and actually doing a screening of a documentary that dives into the challenges around maternal health for Black women. And they actually have 3 to 4 times more, or 3 to 4 times greater mortality around maternal mortality for Black women. So the question is then, how do we advance equity through value-based care? We've recognized, and I'll go back to the very start on my opening slide, which said equity is the North Star for value. Equity has to be the goal, and value-based care can be the means and the way that we try to drive that. So CMS has recognized that. They've done a strategy refresh. They've identified 5 areas to focus on. One of those is health equity and advancing health equity. It's their second objective, and all new models will be created with equity in mind. It's just amazing that we've gone through so many years without equity being a priority. And thankfully now we're at the point. It took a pandemic, it took a huge social unrest movement to get us here, but we're seeing it and recognizing the importance of this. So CMMI, to come out the gate, they've started a new model, which is the ACO REACH model. It has, again, similar to the next gen ACO, they've brought over the greater levels of risk that providers can take. They're going to require that providers create and deliver on health equity plans. They're not telling you what an equity plan looks like. You got to make it up on your own. They're wanting to collect and report on equity data. They're not giving you a lot of definitions and guidance on how to do that. This is a discovery process, and they recognize that. So there's discussions around convening these REACH ACOs to be able to learn together and discuss ways to collect and report data. And you have to prove measurable reductions in health disparities. One great benefit of this program is they're actually giving upfront investments. And so it's not a retrospective payment that you have to wait for 18 months before you make up some of the investment that you put into it. They're going to give money upfront, and then there will be a reconciliation after the fact, after which they'll decide if there's shared savings or shared losses that need to be adjusted. So with that, it's a great example of CMS taking some initiative. There's also been a recognition that value-based payment can be a super useful tool for addressing social determinants of health. We know that social determinants take up so much of how healthy a person is. You know, it determines far more than the time they spend in the hospital or in the clinic. So being able to have the flexibility to spend money on the things that are going to help patients rather than just the things you're limited to because there's a reimbursement code is a very important concept. And so we've seen a lot of safety net, FQHC providers and others jumping in feet first into the ACO REACH model. It's had much higher uptake with provider organizations in rural areas. So some of the things you should be thinking about as we're thinking about equity in value-based care, partnering with your community-based organizations, collecting data for equity. Intermountain Healthcare did a webinar with me a couple months ago, and they said, we thought, we looked at our data and we thought we don't have any inequities. This is great. Our data shows no inequities. And then they asked the question, are we measuring the right things? And so they had to make some major adjustments to be able to measure and understand truly what equity looks like and how to recognize inequities and be able to address those. Integrating pharmacies, mental health, these are things that provider organizations are trying to do to create a more holistic approach to providing care for their patients. Ultimately, the healthcare landscape is changing. There's huge momentum. I know there's a lot of inertia that says stay the same, the status quo, fee for service. There's so many stakeholders that are kind of digging in their feet into that mentality, but we've got so many innovators and even big organizations like Walmart who are making significant changes into the healthcare economy. And so if you want to stay on top of what's happening in value-based care, I've mentioned my podcast a couple times. This is this was a passion of my executive director, Eric Weaver. He really wanted to do this podcast. And so we've just passed our 150th episode. We just interviewed this past week Leonard Lindenmuth, who's from upstate New York, and he's a director of a rural health ACO. So I think you'll be really interested to hear that when it comes out. I've got a few other episodes about rural health with Sean Griffith, Jessica Barnes, Chip Purcell, Physicians of Michigan, Cumberland Center for Healthcare Innovation out of Tennessee. But these episodes really highlight a lot of what's happening in value-based care currently, and are give great insights to what people are thinking and innovating around. And I was really pleased this morning to get an email from an individual who said that they're working on their primary care strategy in this new system. It's a combination of a couple systems, and they're thinking hard about how to create a new innovative model that's going to make a big difference and not just be stuck in the same fee-for-service hamster wheel. And he just thanked us for the work that we're doing on the podcast by interviewing all these people. And it's the coolest job because, you know, I get to have these stories, weekly. I get to do these interviews, and it's some great examples of the work that people are doing. So I encourage you to visit that page and learn more. Also, the Institute has free membership for provider organizations. If you're working in a health department, go ahead and click the provider organization membership link as well, or the individual link. So we won't turn away health departments and provider organizations. I mean, most health departments are provider organizations anyway. So we offer free membership. You can access our case studies, our market research. We've got a community a network of peers. We host events. We really want to do as much as we can to advance value-based care, to advance health value for the purpose of achieving equity. And with that, I think I'll finish by, just one example really quickly is we recently did a webinar with Dr. Sherney, and he's from the American College of Lifestyle Medicine, an incredible example of how lifestyle medicine, things like healthy lifestyles, eating clean, getting enough sleep, having a strong community, all of these things, how they're more impactful for health, and they're better at improving equity than many other things that we've addressed. And so we wrote a white paper with him, and we did a webinar interview. I'd definitely invite you. Those things are available in our community when you sign up for membership. I think you'll find a lot of great information in there. Basically, I want to be a resource for you to discover how to leverage value-based care to drive equity. And with that, I'll finish again by waxing philosophical. And I've gone back and forth on this quote a lot, but it just kind of stands out to me. We are in a free country. We've made a lot of decisions because of the freedom that we have that have kind of led us down paths that we don't necessarily love where we're at, but we have the freedom to find our way. And I'm grateful for that, and grateful for the opportunity again, just to talk to you and give you some insights about value-based care and health equity. I know the equity piece was a little shorter than maybe you wanted, but I think that it's important to have that context of value and where we're at and what needs to happen for equity. I've got a lot more resources I'd love to share with anybody who's interested. I'll go back to this slide. Feel free to reach out via email or connect with Casey and Austin, and we can have some more conversations. And I look forward to answering any questions that you guys have, and connecting with you down the road.
Yeah, thanks, Daniel. I really appreciate this. So from the chat, and this was a while ago, I apologize, Suzanne. But can you just remind us what an SNF and IRF are?
Yeah, definitely. A SNF is a skilled nursing facility, and an IRF is inpatient rehabilitation facility.
Okay, awesome. And then if anyone else has questions, feel free to chime in. You can drop them in the chat, or you can unmute and ask those.
I know it was a lot of information. It's kind of like drinking from the fire hose, and some of it may have been a little bit redundant, and some of it, hopefully, there's enough new information in here that it makes you think. And I just can't express how important achieving equity is. And it all starts with recognizing it and not assuming that we're beyond that. We're definitely not beyond it. We have some major problems we have to overcome and solve for. And there's no question in my mind that value-based care is the way that we drive to that. And it may not, I know I've talked a lot about payment models. I don't believe payment models are the only approach. In fact, my podcast episode this week was with a gentleman who's a healthcare economist, and he's created a new model that just depends on the relationships with the employers and their employees, and serving patients through virtual care, leveraging telehealth to a very high level, and only occasionally, if necessary, having an in-person visit. He's got a really neat model. And what Walmart is doing with adding clinics in their stores and making prices transparent is a huge move toward providing value to patients. There's a lot of investment from private equity right now going into the Medicare Advantage space, and these enablers and these aggregators. There are just so many different levers that are happening right now that are really advancing value. To limit it to say that it's only these APMs and these contracts and what CMS is doing is having a myopic view. It'll be a hugely important effort from CMS, and everybody looks to CMS for direction and leadership, no question. But we have a lot of things happening just in industry as well that we need to have continue to happen and that we can get behind and support. And I encourage you guys to look into those and listen for opportunities that that resonate with you and that you want to learn more about.
Yeah. Thanks again, Daniel. We really appreciate you being here today. And I will make sure to get this recording sent out to everyone, as well as a copy of the slides so that you can go through those and click on the links. And Daniel plugged it a few times. I'll plug it as well. He's got his podcast, and can't recommend that enough. Just so much information there about value-based care, equity, other topics pertaining to healthcare that are so important. So I'll make sure to include a link to that as well. But if there are no other questions, we'll go ahead and wrap up here. Thanks everyone for being here. We've got one more session. So we're in the home stretch now and excited to wrap this up in a couple of weeks.
Thanks, Austin.